Well, thank you to Jeffrey and Rod for inviting me. I'm really, really honored to be here, and I'm so pleased at the turnout. This was not the case when I was in training to be an oncologist, that people were terribly interested in cancer and nutrition. And first of all, I'm not at the moment a professor. I've been one in the past, but at the moment I'm a recovering academic. But, I've had a very blessed career because when I was 7 years old, I knew what I wanted to do. I wanted to be a physician, and I wanted to treat cancer patients, and I wanted to use nutrition to do this. So that's good, right? But I think some of you already know where this is going. So I studied hard. I studied hard through high school. I got into a good college, and my dream was to be at Stanford for oncology, where the first, some of the first cancer cures had come out in the 1970s and 80s. And so I got into a great medical school. I did my residency. And just before my residency, though, I started to have some misgivings about this cancer and nutrition idea. So I took a year off to go and get a master's degree in epidemiology in the public health school at UC Berkeley, because that was where nutrition and cancer research was being done. It was only in epidemiology, and we were looking at large groups of people at a time and seeing what they ate and seeing how much, kind of trying to correlate that with how much cancer they got and what types. Well, that was a really bad experience. When I came out of there, I did have some misgivings about my entire career choice. I mean, I had had none until this moment. But I went back into clinical medicine, did my residency, and I worked hard, and I got into Stanford Oncology. Okay, and I wanted to sit at the feet of all of these researchers who were looking into nutrition and cancer. Well, I got pretty depressed by the first 3 or 4 months in, because all we were doing was chemotherapy. We would give our patients chemotherapy. We would try to rearrange the 20 or so chemotherapy drugs that we had in various combinations to try to make things better for these patients. And it really didn't have much effect on the outcome. And I got more and more depressed, and I decided, this wasn't for me. I'd made a big mistake. I was going to go open, I don't know, a health food restaurant or something and get my nutrition yayas that way. And one of my mentors came up to me and said, "What's the matter? You look like you're about to quit." And I said, "Yes, I hate chemotherapy." And he said, "Well, we all hate chemotherapy." I said, "You do?" "That's all you do here, And he said, "What are you interested in?" I said, "Well, I'm interested in how food interacts with disease, especially cancer." And he said, "Well, we all know that it does, but it's the wrong question right now because we have no tools with which to study this." He said, "If you stick with oncology," and the next thing he said made me stick with oncology. He said, "If you stick with oncology, in the next 20 to 30 years, that will change. We will develop the tools we need to actually study how food affects a particular patient." Because studying how food affects thousands and thousands of people is pretty useless, because a food affects a particular food or a particular diet affects different people differently, as you all know. So I have nothing to disclose. I'm going to talk about how you decide, what you eat. And I'm going to say it's a moving target. This gentleman thinks he's about to have a nice lunch. But things are changing, and things are changing rapidly in cancer research as well. So first thing to think about is that not all cancers are etiologically related to diet. All right? We know that some cancers are. We have some information about that, and we'll talk about that in a minute, but a lot of them aren't. And I've got a long list here, and you will get the slides later, and you can take a look at this. But basically, viruses, environmental exposures, other things that we don't understand play a role in the etiology of cancer. It doesn't mean that that the diet isn't important after a cancer diagnosis in these tumors, and we'll talk a little bit about that. It may be important in helping the treatment. So common cancers that may be etiologically and certainly are related to diet and are certainly promoted by dietary indiscretions are very common tumors that you will have seen if you are a practitioner. Breast cancer, colon cancer, endometrial adenocarcinoma, very closely linked to hyperinsulinemia, and several others. So the way that we got to knowing that there was a connection between diet and cancer is through looking at diabetes. This is one way. And diabetics, especially type 2 diabetics, tend to have a higher insulin circulating level early in their course at least. And they also often are, paradoxically, even though they're insulin resistant, given insulin to take exogenously. And we can look at the amount of insulin someone takes either over time or the actual dose. And this forest plot will show you that all of the dots over on the right of that vertical line are actually increased risk of various types of cancer with insulin use. And so that's another clue. Another thing that's really, really interesting that was not, that's been around for a long time, but I don't know why nobody's looked at this very closely. Higher total and LDL cholesterol fractions actually seem to be protective against certain types of cancer, at least. If a patient has a higher total cholesterol level and LDL level, they actually respond better to chemotherapy. Did you know that? Okay. And they have a better cancer-specific survival after diagnosis. So, I mean, if you've got cancer, you're not going to be running around thinking, oh my God, am I going to have a heart attack if I eat that stick of butter? I mean, that's just not the first thing on your list, and it shouldn't be if you look at these statistics. And certainly triglycerides, which are a proxy for a carbohydrate in the diet, high triglycerides are detrimental in at least one particular type of breast cancer that we've looked at. So I'm going to divide this talk into 3 parts. We're going to talk about moderate carbohydrate restriction, and I'm going to talk about using moderate carbohydrate restriction. By that, I mean 100 grams of carbohydrate a day. We had to pick something, and that's what I picked in my clinic. And we adjust that up and down as we need to. And that we're going to talk about in reference to 2 common cancers, colon cancer and a certain common subtype of breast cancer. We're going to talk about the ketogenic diet in reference to several oncologic situations, one of which is glioblastoma multiforme, and other is cancer cachexia. And we're going to talk about some emerging evidence that gives us some guidelines as to when not to use the ketogenic diet. And the third part I'm going to talk a little bit, and this won't be as long, I'm going to talk a little bit about caloric restriction and intermittent fasting. So let's go. So we know from a study based at Harvard, the CALGB cohort of stage 3 colon cancer patients followed over many, many years. Their diet was dissected. This is an observational study. The diet was dissected over many layers. They called it the Western diet, or was it? And they always show a picture of a cheeseburger and French fries. You've seen the Western diet versus the prudent diet. So you can tell where they're falling in their bias there, which was lots of fruits and vegetables and healthy whole grains. Well, that didn't seem to matter. The Western versus the prudent. They were surprised. We were all surprised. That didn't matter in survival of stage 3 colon cancer patients very much. What did matter was daily carbohydrate intake. And in that, the paper studied, published based on this study, they were using the glycemic load as the proxy for carbohydrate intake. And that's a really clumsy and inaccurate way of measuring things. But I tried to look at this study and pick out what the patients who were doing well were eating in terms of carbohydrate per day, and it was about 100 grams a day. So if a stage 3 colon cancer patient carried on after diagnosis a low carbohydrate diet, and in this case it was a glycemic load of about 100 per day, they had much less recurrence. And the effect was actually greater than the effect of the chemotherapy that's used in treatment of stage 3 colon cancer. That says more about the dismal ineffectiveness of the chemotherapy than it does even about the diet, but because the effect was measurable but not huge. There was a caveat there, though, that I want you to really notice here, and that was this only was the case if the BMI was 25 or greater. So if these patients were overweight or obese, that was where you saw this effect, and we don't understand that. But in the thinner patients, we didn't see this effect with the low carbohydrate diet. So the second case I want to talk about where in the cancer clinic you might want to consider restricting moderate carbohydrate restriction is in breast cancer. There were 2 interventional breast cancer trials, very large ones, very famous ones, the WELLS and the WINS trial. WELLS stands for Women's Healthy Eating and Lifestyle Study, and the WINS was the Women's Interventional Nutrition Study. And they were carried on for many years, 8 years, something like that. Breast cancer patients after diagnosis were randomized either to a low-fat diet, in the case of the WINS trial, or a low-fat plus huge numbers of fruits and vegetables per day, plus high fiber. In the Wells trial, they really went nuts. They even measured the carotenoids in these patients' blood to make sure they were paying attention to the diet and doing it. The control groups were given pamphlets or advice on a healthy diet. Well, the results were that there was little or no connection between fat intake and breast cancer survival. And this was a big surprise. I'm sure some of you are old enough, like I am, to remember when fat was the cause of breast cancer. Does anybody remember that? And so when these studies started coming in, it was, this was a real world changer for a lot of us. There was, in the WINS trial, though, a suggestion of improved survival if weight was lost. And the weight loss was rather trivial. I think it was 2 or 3 kilograms, maybe up to 6 pounds, something like that. But if you look at some of the subgroups in these studies, there were some differences. And these, I think, are really interesting, and these are clues as to where we should look. If a woman had no hot flashes before her going on the low-fat diet in the WINS trial, then she had a better response in terms of less recurrence on this diet. If she had an ER negative, estrogen receptor negative breast cancer, then she had a better outcome on the high produce, high fiber, and low fat Wells diet. And again, as I mentioned, if weight loss occurred in the WINS trial, there was a measured improvement in survival. But then somebody decided to look at carbohydrates, and this is at UC San Diego. They did a little what's called a nested case control study of women with postmenopausal breast cancer that was estrogen receptor positive. So postmenopausal breast cancer that's estrogen receptor positive is the most common kind of breast cancer. So 70% of breast cancer patients, this is what they have. And postmenopausal breast cancer means that you're diagnosed with your breast cancer after menopause. Not that you're diagnosed with breast cancer sometime before menopause, then you go through menopause, and now you're a postmenopausal breast cancer patient. No. So these were all women that were a little bit older when they were diagnosed with breast cancer. And they had estrogen receptor positive tumors. And these tumors were tested also for IGF-1, insulin-like growth factor receptor expression in the tumor. So you hear that word insulin again there. What they found was really interesting was that decreasing the carbohydrate intake by 27 grams a day after the diagnosis of breast cancer was associated with half the risk of recurrence. Now, I'm going to tell you that's better. That's a lot. That's better than most of our drugs, tamoxifen, chemotherapy, and things like that can do. These patients also had tamoxifen and chemotherapy generally if they needed it, and radiation and surgery, all of those things. So I'm not saying that, please don't go home and say, well, I'm not going to have treatment for my breast cancer. I'm just going to cut out 27 grams of carbs a day and I'm going to be fine. No. So the effect was strongest in the patients whose tumors expressed IGF-1 receptors. And if that particular protein was present in the tumor, that suggests that the tumor was able to attract IGF-1 from the blood and use that as a signal to grow. And that effect was enhanced with carbohydrates. So this protein was expressed very strongly in the very few African Americans in this trial. I think there were 11 or something like that. And I think there were 17 or 18 Hispanics, and 80% of them had tumors that expressed this particular protein. 40% of the Caucasians, who were by far the largest group in this study, had tumors that expressed this particular protein. The take home from this is that you're not going to hurt anybody by taking away 27 grams of carbohydrates per day after their breast cancer diagnosis. That's about the amount of carbohydrate in one banana, 1 or 2 slices of bread, depending on how thick it is. It's just not a big deal. Do it. Do it across the board in any of your patients who have postmenopausal estrogen receptor positive breast cancer. It's hard to get the test for IGF-1 receptor right now. It's not impossible, but it's expensive, and you have to go through laboratories that are doing research on it. It's just a hassle. So it's no comparison between just cutting out that banana a day. So these are some of the statistics that compare in a clumsy way Okay, we're comparing apples and oranges here, or I wish I could think, I don't know, bacon and sausage for this crowd. But you see that chemotherapy gives you a 20% decrease in breast cancer mortality, and tamoxifen a 31%, chemo plus tamoxifen 45%, and one less banana a day, a 40% decrease. Now we're measuring, over in the top half over 15 years and in the bottom half over 5.1 years. It could be that if we go across for many more years, maybe those statistics will change. But this is such an innocuous intervention that I just want to put that out there and get people doing that. So these are just my bloviating about why you can't take this as gospel yet. But I want you to kind of take it as, I don't know, just say that Dawn told you to do this. So just to recap, so moderate carbohydrate restriction in my clinic, that's 100 grams a day, and I have them measure and write it down and everything, and I'm not as nice as Dr. Westman. But anyway, ER positive postmenopausal breast cancer, yes. Stage 3 colon cancer, if they're overweight, yes. And just start by restricting the carbs to 100 grams a day. If intermittent fasting and perhaps caloric restriction might be helpful if patients are interested in those kinds of things, but we're still looking at that. So why is this happening? You've all heard of the Warburg effect by now. And what this means is that cancer cells, we don't know why, have a change in their mitochondrial function. You can call it damage. It probably is in some cases. We don't know why that occurs, whether these are normal mitochondria that are just reprogrammed by some kind of genetic change in the nucleus of the cell, or whether there's some kind of poisoning or damage to the mitochondria per se. My sense is that probably both pathways will lead to cancer, but that's still to be determined. So in a normal cell, one molecule of glucose will net 38 molecules of ATP going through a process carried out in the normal mitochondria called oxidative respiration. Uses oxygen, produces carbon dioxide. Well, in a cancer cell, that process is obliterated for some reason, and cancer cells are forced to use an older pathway that was developed in the evolution before there was oxygen on Earth. Okay, I think that's kind of interesting, and I could talk about that for 2 hours, but you should call me up if you want me to. So in that, if you follow that pathway in a cell metabolizing every molecule of glucose, you only get 2 molecules of ATP. So do the math. It's about 20 times greater. There's a 20 times greater glucose requirement in cancer cells compared to a normal cell. That's a lot. All right, so this is a PET scan, and you've all heard of PET scans. What a PET scan is a picture of how your body is using glucose, where the glucose is going, who wants it. This is a normal person, and you see that blob that I've got a red arrow there saying pointing to the normal heart. That's that blob in the chest there. There's 2 blobs just below that. Those are the kidneys. They like lots of sugar. And then there's the normal bladder down in the bottom in the pelvis there. That's where the contrast medium is collecting, and so we can see that in there. And that's just kind of a landmark. I want you to notice that bladder in this next case. Well, we can't see the bladder in this case, but this patient has a left-sided lung cancer. It's on the right side in your picture, but in the chest, you see that black blob in the right, in the right side. It's the left lung, and you can see the 2 kidneys and the heart a little bit collecting some of the glucose there. This is a patient with advanced metastatic cancer. I don't know what the primary was, but all of those black blobs are tumor, and you can see the bladder down there, so you know that this person is actually collecting the scanning material. So we're going to talk this in the second part about the ketogenic diet, glioblastoma. It's being studied in advanced cancers. And I want to say right here that Jeffrey told me today that a patient of his, a 24-year-old named Beatrice, he wants to honor her with this at this meeting. She had a glioblastoma, and she did everything she could, including the ketogenic diet. And she was to speak here. She was doing very well. And she was to speak here, but she died suddenly, unexpectedly, it sounds like 2 weeks ago. So just to honor Beatrice, we're going to just mention that here. So we don't really have a lot of answers for glioblastoma, but we're starting to be able to at least look into and peer into the interaction between some cancers, including glioblastoma, and diet. So let's get started. So what is ketogenesis? That's the goal of the ketogenic diet. It's the production of ketone bodies, as you are all already know, or are better experts than I am, a lot of you. How do you get into ketosis? You can fast, you can exercise, very low carbohydrate intake. That's what we're going to talk about here. There are three major ketone bodies in our metabolism: beta-hydroxybutyrate, acetoacetate, and acetone. And this is the response you will get when you talk to physicians or nurses in the cancer clinic and say, well, I'm a cancer patient and I'm going to go on the ketogenic diet, or would you please tell me about the ketogenic diet because I want to go on it because I heard that it might be helpful. And what the problem is here usually is that they're confusing it with something called ketoacidosis. Ketoacidosis is a specific condition that occurs in various medical metabolic states, such as end-stage alcoholism with liver damage. The most common scenario for ketoacidosis is type 1 diabetes. And that happens in type 1 diabetics if they forget or can't get a hold of their insulin for several days. They will go into ketoacidosis. The ketone levels are much higher than we see with dietary ketosis. The ketone levels are 15 to 25 millimoles. This is not what we see in a ketogenic diet, where the ketone levels are much lower. Ketones are acidic and do cause an acid-base shift if they're in great high amounts. But ketoacidosis is not caused by the ketogenic diet. So a typical ketogenic diet might be 85% fat, 10% protein, and 5% carb. This is just a starting place. You will have to adjust with your patients, and I'm not going to go into how to do this. There are people much more qualified than I to help you get your patients into ketosis by adjusting the diet and with dietary planning and all of that. But that's a typical starting place. So let's talk about GBM, or glioblastoma multiforme. The 5-year life expectancy is given at 0. All right. Now, there are people who have survived this for longer periods of time. So I want to just put that out there. That does happen, that there are these outliers, and those people should really be studied. But the ketogenic diet in animal studies has been very, very promising. And what we're trying to figure out in our current research with that is when and how to use it and what to mix it with. So this is from a mouse study, a rodent study of ketogenic diet versus normal mouse chow, whatever the hell that is. And the red line goes out farther to the right than the black line. The red line are the animals on the ketogenic diet. The black line are the animals on the standard chow. And you see that all of the standard chow mice are dead somewhere between day 30 and 35. Most of the ketogenic diet mice are dead too by about day 40. However, there were a few that just kept going and going, and the researchers got tired of waiting for them to die, and they ended the study at 150 days. And when they did finally dissect these animals, there was no cancer found in their body. Now, we cannot say for sure that that was because of the ketogenic diet. I mean, when I was an undergrad, I used to work in these labs, and you have no idea how many test tubes and injections and things I dropped or put into the wrong mouse or whatever, So this has to be repeated before we can say, at a different lab, before we can say that this is truth with a capital T. But this is very, very provocative. So the next round of studies looked at adding radiation to the mix. And look at this. So here we're getting, now we're cooking with gas, okay? This is, the blue line, nobody dies, about 70, 78%. They just keep going. All of the mice on the normal diet, even though they had radiation, are dead. At 150 days. Here's the old. They died at day 33, so they got with the radiation, they got a little bit. They got out to 150 days. But look at this. Over 75% of the mice on the ketogenic diet with radiation are still going at the end of the study. So that's really interesting. So radiation therapy. I want to suggest you consider, if your patient can handle it, putting your patients who are going through radiation, some of them on a ketogenic diet during radiation. And the reason for this is that there's differential DNA repair between, especially in glioblastoma, between normal brain cells and cancerous cells. And this is exacerbated with radiation, and it's exacerbated by the ketogenic diet. So there's a lot of synergy happening when you put those two together. Ketogenic diet decreases insulin and IGF-1 signaling, so that's a good thing. When you put a normal cell, when a normal cell is exposed to a ketogenic diet, to ketone bodies, it will go into a state of dormancy, meaning it won't tend to in a good way, tend to not divide. If it was going to, it might wait a while, and that's a good thing. So angiogenesis suppression, that means that blood vessel growth into tumors are decreased, and that deprives them of nutrients, oxygen, et cetera, waste removal. So that's all good. So that's how, how we think ketosis and radiation interact. So I said I was going to talk about when we shouldn't use the ketogenic diet. And, so this is a picture of a patient with cancer cachexia. And you would think a patient who's lost a lot of weight already, you don't want to put them on a diet that's going to cause more weight loss. And that's what I thought. Well, I was wrong. So it turns out that a ketogenic diet is great for cancer cachexia. So when you see this, go to the ketogenic diet. Cancer cachexia is caused by inflammation. Cancer cells create a lot of inflammatory activity. It's kind of a storm, a mess, really. What they're doing is trying to protect themselves from the immune system, and maybe there's some misdirection there. But the ketogenic diet, because it decreases reactive oxygen species and other kinds of damage, does tend to also calm down inflammation. So consider the ketogenic diet if you have a patient with cancer cachexia. And this is a list of checklists that doctors use to try to decide whether the patient has cancer cachexia, and that's fine. Basically, it's very rare in the early stages of cancer. Early stage cancer patients, for instance, patients undergoing chemotherapy for breast cancer after complete removal of the tumor, they don't have cancer cachexia. But patients in the end stages of cancer, 2/3 of those patients will have cancer cachexia. It's more common in solid tumors than in leukemias, but it can happen in those too. Weight loss greater than 5%, a BMI less than 20, those are all danger signs. Muscle wasting is the main thing I want you to go away from here thinking now. It's the loss of lean tissue is the defining factor of cancer cachexia. You can have an obese patient who has cancer cachexia, and those patients need to go on a high-fat diet. This is a picture of this. On your left is a patient with normal musculature, no cancer. On the right is an obese patient with very little musculature. So if you look at the white, this is a patient who's getting a picture through the pelvic region, and their feet are toward you and their head is toward me, and you're looking up toward their head. In the left-hand picture, you can see the bones nicely transected there, the vertebral column, the hip bones flaring out to the side there. And attached to the hip bones on both sides, both ends of the hip bones, you see lots of nice gray fat muscle. And you see it extending around the front of the abdomen. And between the muscle and that white line, that skin, that white line, that's the layer of fat. It's very thin in this patient. If you look over on the right side, find the hip bones and the spinal column. If you see the round spinal bone in there and you see that gray passing through there, that's likely some tumor. But if you look at the hip bone flarings and you look at the space between the hip bones and the spinal column, you'll see that the muscle that's big and fat and juicy on the left-hand picture is kind of skinny and weak looking. The muscles attached to the front of the hip bone and coming across the abdomen are almost non-existent. And if you look between the thin muscle layer and the skin, the white line, you see all of this fat. So if you look at this patient and say, well, they don't have cachexia, cancer cachexia, because they're obese, their BMI is 30, you'd be wrong. So just be aware that cancer cachexia has to do with the loss of lean muscle tissue, not necessarily the loss of fat, although that can occur too. So now this is an emerging idea. I don't know where it's going to go, but there was some recent publications involving a particular mutation in a gene called BRAF, a mutation in the 600th codon exchanging valine, I think, for E, which is the code, might be the code for glycine. I don't know if any of you know the code, the amino acid code E. Shout it out. And it showed that in this case, if this particular mutation was present in a cancer, the cancer was able to use ketone bodies, especially acetoacetate, to grow. Now, this mutation isn't present in all cancers, but it's pretty common. And you've heard people say, well, most cancers have this abnormal glucose utilization, and you hear numbers bandied about, 5% don't, 10% don't, 15% don't. We don't really know what that is, but if a cancer doesn't light up on a PET scan, that's a clue. And a lot of melanomas, a lot of prostate cancers don't light up on PET scans. Well, that's interesting. And this might be why. Now, the answers aren't in yet, and we're just starting to look at this. But so, for instance, melanoma, 50% of malignant melanomas do express this mutation. And that's actually exploited with drugs that target this mutation and to good effect. Hairy cell leukemia, which is a rare leukemia, the BRAF V600E mutation is pathognomonic for that. That's pretty much, if you've got that in a blood cancer, you've got hairy cell leukemia. So you may not want to use a ketogenic diet in somebody who has hairy cell leukemia right now, unless you have a really good reason for it. Colorectal cancer, 10%. 10% will express this particular mutation. Prostate cancer, we think it might be about 10%, although that's not as carefully studied, and multiple myeloma, a few of them. So you can test for this mutation. So I would suggest you do it if you're considering the ketogenic diet and you have any questions about that. This also brings to bear, I heard somebody hiss here, statins. There may be a role for them in this particular setting if there's a mutation in this in the tumor that's relevant. So prostate cancer right now, there are a lot of oncologists who are using statins to good effect in certain prostate cancer patients, and it may be because of this, but again, this is early. So, summarizing part 2, where to use a ketogenic diet? Use it liberally in cancer, okay? Keeping in mind the BRAF V600E mutation, but use it during radiation in any tumor if the patient can tolerate it. Definitely use it in GBM if the patient's interested. It's difficult for patients who have some brain dysfunction to even patients who don't, to use the ketogenic diet at first. It takes some getting used to, but definitely consider that. And there's a lot of research. I think there are 14 studies ongoing right now using the ketogenic diet in glioblastoma around the world. Advanced PET-positive cancers where everything's been exhausted, give it a try. Cancer cachexia, definitely go for that. Whether the ketogenic diet, especially with caloric restriction, may be useful in chemotherapy of all sorts is under investigation, and it's of great interest to me. So lastly, I'll just touch upon caloric restriction and fasting. The reason that this may be effective is that cancers use things besides glucose for fuel. And even after some period on a ketogenic diet, there seems to be some adaptation in many tumors to get around that and begin using other fuels, proteins, amino acids, and fats instead of glucose. So what does that mean? Well, it means that you might be better off not eating, all right? Okay. So there was an interesting study recently that caught my attention in non-small cell lung cancers. There certainly was enhanced glucose oxidation in most of these tumors, all right? That was true. They were doing the Warburg dance. They were doing it. There was heterogeneity, though, between one side of one patient's tumor and the other side. So in other words, if you biopsied an inch away, took 2 biopsies, one side of the tumor might be using a lot of glucose and the other one was using, glutamine or amino acids or something like that. And so it was not only between 2 different subjects. So this patient's lung cancer metabolizes glucose a little bit differently than this patient. It was actually within the same subject. And lung cancers in this study used multiple energy sources. If you deprived them of one, they would just not miss a beat and just go on to another one. So here are some of the things that we know can fuel cancers in that particular, following that particular idea. I want to point out one of them, which is glutamine. Glutamine is used widely in the alternative cancer realm to prevent gastrointestinal problems from chemotherapy and also to help prevent chemotherapy-induced neuropathy, both of which it does very well. However, it appears that glutamine does enhance growth of many tumors, so I recommend against large glutamine loads by like 500 or milligrams to a gram at a time would not be wise. So here's a glutamine PET scan. We can also label glutamine, just like we can label sugar, and take pictures of glutamine uptake in cancer. You see this patient is, cancer is very happy with glutamine and will use it to grow. So chronic caloric restriction has been known to prevent cancer and other diseases of aging for almost 100 years in animal studies. What does it mean? Chronic caloric restriction is cutting back the daily caloric intake, and most of the studies use 25 to 40%. It extends lifespan in many species. Underweight is a problem. If you don't eat enough every single day, you're going to lose weight. Intermittent fasting doesn't have that problem of weight loss, and it also seems to work just as well, or perhaps a little bit better in some cases than chronic caloric restriction. So I like to use intermittent fasting in my cancer patients, and in our animal studies are very, very convincing that intermittent fasting sensitizes tumors to treatment, it protects normal cells from the side effects of the chemotherapy, and it slows tumor growth even without chemo. Now, I want you to pay attention right here to the word slows. It doesn't reverse it. That cancer is still growing most of the time in patients who are fasting. It's just growing more slowly. But the final thing is that intermittent fasting potentiates chemotherapy. So I like to have my patients fast for 24 hours to 48 hours before a chemotherapy infusion and to carry on after that if they can. And a lot of patients really like it. They find it easy. This is a mouse rodent study of melanoma. It shows that there's better survival if you combine fasting and chemotherapy. This is a mouse model of human melanoma, meaning human melanoma cells were injected into mice. It's not a great model. Most of you will think, well, if they're injected, if they're injected into mice, why would they even grow there? Well, these mice have to be immunosuppressed, so that creates other problems. But the main takeaway from this is that chemotherapy alone and fasting alone and doing nothing all had the mice die at about day 35. But if you combined chemotherapy and fasting, you got some of those mice out to, you got at least one of them out to day 46. So that was the takeaway from here is combining the two is better. So why is this? Dividing cells are sensitive to treatment like radiation or chemotherapy. That's when you get them. When they're dividing, they've got their DNA all opened and spread out through the cell, and it's not all tightly coiled up in little balls. You can kill those cancer cells when that's happening. When normal cells are starved, they immediately retreat from going into the division phase of the cell cycle. And so they're protected somewhat from the side effects of chemotherapy. Cancer cells who are hungry cannot stop growing. They have to. They have their grow switches broken in the on position. They have to keep growing. So that's how fasting makes it possible to kill cancer cells while protecting normal cells. So 10 patient volunteers came to Walter Longo at USC, who's doing a lot of this cancer and fasting work. And they said, well, we've been reading your research and we want you to fast us and study us. And he said, oh, no. I'm not doing that. And they said, well, fine. We're going to do it on our own and you just take some notes, okay? So he said, okay. And what happened was, I'm kind of making this up. I'm just reading between the lines in his paper. So if he says that's not how it happens, you believe him. But his paper just showed up. Suddenly these 10 volunteers with all sorts of different cancers. This is not how Walter Longo works. His studies are really minutely planned out. Nobody just shows up and anyway. So they had different types of cancer. They were fasting all different periods of time, but long times. And the results were good. They felt better. They had fewer side effects. they liked it, and the oncologists were surprised because they thought, oh, these guys are all going to get worse. Their tumors are going to grow. Their tumor markers are going to go up. Well, that didn't happen. So that was about 10 years ago. Another thing, one of the last things I'll say, I'm almost done here, is fasting can reverse a non-solid tumor in animal models, and a particular type of tumor called ALL. And what I want you to read here is that fasting alone, in these cases, robustly, okay, not just itty-bitty like in those epidemiology studies, robustly inhibits and reverses the leukemic progression in acute ALL. Now, it didn't work in a different type of leukemia that involves a different cell line, so that's something to be aware of. And the mechanism behind this was thought to be leptin sensitivity, an enhancement of the leptin sensitivity with fasting. The overnight fast is the way to start with your patients. All of your cancer patients should be fasting 13 hours a night. And that means that if they put their fork down at 6 p.m. from dinner, there's no food, no calories until 7 a.m. And the first thing that will happen is your patients will say, oh, they'll come back and say, I've been doing it. I've been fasting from 6 p.m. to 6 a.m. No, that was the control group against which this 13 hours was compared. The control group didn't have this effect. So it takes 13 hours minimum to get the effect of fasting, which is to decrease the risk of, or it's associated with a decreased risk of breast cancer recurrence. I would say do this with all of your cancer patients. I would say do this even if you don't have cancer. This is easy for most people, and it gets you into the slight state of ketosis, most people, which we think is beneficial. And we think the mechanism is, again, I think it's getting into ketosis, but the authors of this study thought it was a lowering of the hemoglobin A1C. So occasional short fasts to review. They enhance the effectiveness of chemotherapy. They decrease the side effects. They're safe, and they may be necessary for general health. Fasting is not fatal. There's a report of a man who, I think he weighed over 400 pounds, who fasted for a year, took a vitamin pill a day, lost over 200 pounds, and was perfectly healthy. And I think it's said that the normal person of normal BMI can last for 60 or so days with no calories. So, you know, skipping lunch once in a while will not kill you. I've been asking people how long they think a human being can go without food, and the answer has been 4 days. This is the American Cancer Society. We have a lot of work to do, folks. A lot of work to do. This is the American Cancer Society's instructions to patients currently on cancer treatment. And this is only a partial list, and I checked. I can't believe that it's still there. So I checked last night. It's still up. And this is what your patients are reading. You know, when they're looking to the American Cancer, which does wonderful work. I mean, there's nothing against the American Cancer Society. They do need to update this page. So in summary, the ketogenic, the moderate carbohydrate restriction in colon cancer stage 3 overweight patients, in estrogen receptor positive postmenopausal breast cancer patients. Okay, at least get them on 100 grams of carbs a day. The ketogenic diet. Glioblastoma multiforme, consider it, all right? Advanced incurable cancers of adults, any patients with any type of cancer on radiation, and in cancer cachexia. Intermittent fasting during chemotherapy and possibly during radiation. The animal studies are suggestive. Everybody should be fasting 13 hours a night, most nights, and I don't know, but longer fasts occasionally may decrease cancer risk in people who don't have cancer. These are questions and issues that are still up in the air and will be for a while, I think. Do we want to use exogenous ketones to get our patients into ketosis? You know, there's a lot of interesting work going on there, and so I'm curious to know the answer. Should we combine fasting, caloric restriction with ketogenic diet? I think the answer might be maybe. Is fasting versus the ketogenic diet better? Maybe. Should we ever use statins and a low-fat diet? Well, we'll have to wait and see, but that's another maybe. Should we restrict protein or amino acids in some of these tumors? The answer's being looked at. And what about diet cycling? fasting, ketogenic diet, low-fat diet, repeat. Those are some ideas out there. So thank you very much.